Today, I have the pleasure of introducing Dr. Stephen Coca today with our division of nephrology, one of our associate professors here. He was here last year. He gave us a very exciting lecture on kidney failure and heart failure.
Yeah.
Really good lecture. So we're happy to have him back today to talk today about some of the newer diabetic medications and how that pertains to cardiovascular medicine. So thank you very much, Dr. Coca.
Thanks for having me. Well, good to be here. I want to talk about this new drug class because it really is, I don't use this term loosely, it's the only class that I've used this term for. I think it is a game changer in so many spaces. These are my disclosures, and the only one that may be relevant is I had a little consulting gig with Janssen that started like in 2017 related to possible acute kidney injury from these drugs. And too much to my chagrin and my wallet, bank account, I got 0 cases because I think all the data that have come out that are overwhelming in terms of kidney protection have thwarted any potential lawsuit. So I think I can drop that one next year. I think there's a 3-year rule, and it's stupid because I'm not conflicted on this, and I got no money. End-stage kidney disease going up, right? You guys know this, diabetes, obesity issues. And diabetes accounts for about 47%, roughly 50% of all cases of ESRD in this country. These were the 2 landmark studies that came out. They came out of my intern year, internal medicine residency, the renal and IDNT trials. These are why we prescribe ARBs, and they by extension ACE inhibitors to patients with diabetic kidney disease. Now, this small group, hopefully get a little bigger, but what do you guys think of that looking at these? They're not Kaplan-Meiers because they don't start at 0, they're cumulative incidence curves. What do you think? Is this is what we've been doing for the last roughly 20 years to treat our patients. But looking at the data, what do you think? How robust is it? Not impressive at all, Andy. Barry Brenner, who's the godfather of nephrology, I know I'm not speaking to a nephrology crowd, but Harvard, written all the textbooks. But, we're selling this as the next penicillin, okay, for strep throat. And it really, if you squint, these are not that impressive. And so when I've given talks in my biomarker talks for my research or for where we needed to go, you can shade this area, and you need to get this line down here, right? There was so much more room for improvement. So I know you guys are mostly practicing inpatient medicine, but just to say someone's on an ACE or ARB does not mean they're protected. So many patients with DKD were still progressing. And so there's been such a race by pharma and industry and investigators to try to find better treatments. There's a huge gap, the necessity, right? And all these various drug classes and even more have come out in the last 15 years, been tested, and have failed. Tool RAS blockade was exciting for a while, well, for some maybe. Bardoxolone was going to be the next wonder drug, didn't improve outcomes at all. All these things completely null, if not harmful. So we had nothing else besides ACE-ARB. And it was kind of pathetic, probably our consults from the clinic, same stuff. Continue this, blood pressure control, we had nothing. So that's why I'm so excited. It's from a true passion for doing something better for our patients. So these drugs came out. Now, has anyone seen them or prescribed them? Raise your hands. You've seen them, right? You're not going to you probably haven't started them on patients. Right? These are the various ones. We'll talk about the data on them. How do they work? So there's the sodium glucose co-transporter in the proximal tubules. And normally diabetics are, they have a serum glucose, whatever, 180, 200, and they're filtering glucose. And then you get reuptake by these transporters. And this is what leads to that early hyperfiltration in diabetes. And by blocking it, you can dump glucose, dumping calories into your urine, and sodium. So it's a proximal tubular diuretic. And it's glycemic control and weight loss. And it was originally marketed in 2010 to 2012 when they were coming about. By the way, there were early genetic studies 25 years ago showing kindreds or families that had this knockout of this had like blood pressures 110s and no cardiovascular disease. That's kind of why they chased it. And of course, no diabetes. But how do they actually protect the kidney? I wanted to zoom out a little from the proximal tubule. And for those of you going back to basic physiology, if you block sodium glucose co-transport here, you get increased delivery of sodium to the macula densa. And the macula densa then sends a signal to constrict the afferent arteriole, probably mediated by adenosine. That's not important. So it's this tubular-glomerular feedback. I'm going to have a few more slides on the kidneys in a second. But this reduces intraglomerular pressure. Do I have them out of order? Hold on one second. Yeah, let me just go to here. I should have fixed the order. I'm sorry. Hyperfiltration, as I mentioned, is the thing you want to combat. Barry Brenner, who I mentioned, was the king of this hypothesis. And why we gave ACE inhibitors, ARBs, are to dilate the afferent arteriole and block AT2 constriction of that, to lower the pressure in the glomerulus and decrease shear stress in here and reduce glomerulosclerosis. And by constricting, this was the ACE inhibitor effect on the efferent arteriole, reduce interglomerular pressure. Here, by acting on the macula densa, constricting the afferent, we're doing it just on the other end, reducing intraglomerular pressure, which should protect the kidneys long term. Now let me go back. I'll move these around for my next talk on this. I'm calling it cardio-renal game changer because it's not just the kidneys, and I don't want to be completely nephrocentric. People from kidney disease die from cardiovascular disease. We can do dialysis, even though it can be a miserable existence, but half of the patients on dialysis or even in advanced CKD die of cardiovascular disease. And there's more and more data coming out that these drugs are not just improving glycemic control, not just protecting the kidney from high intraglomerular pressures, but actually directly protecting the heart. There's diabetic heart disease, and it can affect all these. I'm not going to go deep on these data into the animal studies, but these are the summary slides. It can improve remodeling, improve metabolism by shifting metabolism to ketone bodies, prevent apoptosis, and reduce inflammation. And for patients with heart failure, whereas loop diuretics, you're getting sodium excretion, reducing interstitial volume, you reduce intravascular volume to some degree, and that's why we worry sometimes about over-diuresing. But for some reason here with the SGLT2 inhibitors, probably because you reach a new steady state earlier on by this tubular glomerular feedback mechanism, and you don't get these reductions in intravascular volume. And I think that's key. When I show you the complications of AKI and dehydration, which people always mention to me, they're worried about it, they're actually not higher in the trials. And maybe this is why. It's not really causing hypotension or intravascular volume depletion. Now, this is even new to me, but it's, again, coming from these review articles. They may even be blocking the sodium hydrogen ion exchanger in the heart and improving myocardial and myocyte energetics here. I mean, these are, again, a summation of some animal studies. So just the ways it can improve the myocardium. For the rest of the talk, I'm focused mostly on the clinical data. I'm not a basic scientist. I think the top-down approach show it improves outcomes, and then, the scientists can figure out really why it's working. But number one priority, improve the outcomes. You can have the most elegant mechanism in the world, and a lot of those trials and billions of those dollars that were spent on other things they thought were going to work didn't work. So then in the end, who cares, right? Here was a nice summary slide incorporating the heart and the kidney and how it's improving this whole cardio-renal type interaction. You're getting, ketosis, decreasing sympathetic outflow, reducing volume overload, improving vascular compliance, getting rid of the fluid for the natriuresis. It's like a wonder drug doing all these different things. And we talked about the glomerular hypertension, interglomerular pressures. And here's another summary slide. The glomerular pressure, the diuretic effect, reducing albuminuria, that glucose is toxic when it keeps getting taken up by the SGLT2 inhibitors. It's toxic to the tubular cells. So you're improving tubular cell health, reducing tubular injury. There's data that reduces inflammation. You lose weight because you're dumping that glucose and excreting it. And blood pressure does go down slightly too, as you would expect. And I'll show you some of those data. Here's just another summary slide. Okay. So any questions mechanistically on these drugs? Well, we'll talk about the side effects. But these are just mechanisms. So you can see though why it's this, because it's pluripotent. I always maintain if you have a single drug target, are you really going to improve syndromes that are so complex like heart failure, diabetic kidney disease? It's not just one pathway. There's so many redundant pathways. And it's multifactorial, and you need something that has multiple benefits. Pleiotropic, almost like this. This may have more effect than statins. You know, statins is more than LDL, right? Endothelial function and inflammation. So I think these have the pleiotropy you need to combat complex syndromes like heart failure and DKD. So the three trials that started a couple years ago, really the kidney data, these were cardiovascular outcome trials. You guys should know that in 2012, I think, the FDA mandated diabetes trials not only show the reduction in A1C, you have to have cardiovascular outcome trials. And the goal is actually not to show that you reduce cardiovascular outcomes, it was to show you don't kill people more. You have to have net neutral effects on the clinical outcomes, right? Because the ACCORD trial, published in 2008, which randomized people to intensive glycemic control for standard, increase your risk of death by 22% with intensive control. I think that was one of the reasons people got fired up. And as you know, the sulfonylureas have never been really shown to reduce mortality, even though they control blood sugar. So these trials came out. We'll talk about each of them. These are the CVOT trials. And then CREDENCE came out, which was the first dedicated DKD trial, which actually, ironically, started before the CVOT trial enrollments, but it took longer because you're looking not just high-risk diabetes, but they had to have overt nephropathy, and we'll talk about that. So here were two of the key first trials, EMPA-REG with epagliflozin, 7,000 patients, and CANVAS and CANVAS-R, which had over 10,000 patients, the two agents, because the median A1C was 8. I know this doesn't point because it's digital. And everybody had CV disease in EMPA-REG. So everybody's worried about hypoglycemia. Yeah, they initially reduced glucose somewhat by about 0.5 to 0.8 points on your A1C. But then look, this is from CANVAS and this is from EMPA-REG. And by the end, you have like a difference of 0.2% in your A1C. Blood pressure does come down initially, maybe 3-4 millimeters of mercury. Some people argue a lot of this effect is just blood pressure effect. You can never decouple it because you're getting natriuresis with it, right? So the cool thing was, I'll show you the overall outcomes, but heart failure hospitalizations, there was already a signal from these early trials, CANVAS and EMPA-REG, that there was less hospitalizations for heart failure with these two drugs. As you would expect, again, you're controlling volume status better. And the overall outcomes were not just net neutral here, but they were better. Here's the primary outcome from EMPA-REG. You had a 14% reduction in the primary outcome, a 38% reduction in death from cardiovascular cause, the heart failure there, and really similar results from the CANVAS trials. Maybe not as strong a reduction in cardiovascular, but again, statistically significant and beneficial. Kidney outcomes were not the primary outcomes of either trial because I showed you the enrollment criteria, and they were really just enrolled with high-risk cardiovascular status and type 2 diabetes. Post-hoc analyses and secondary analyses of both trials showed benefit for multiple endpoints. Here's EMPA-REG showing no matter which way you cut the kidney endpoint, worsening nephropathy, incident or worsening, macroalbuminuria, doubling creatinine, dialysis, These are huge risk reductions, about 40% on average. That again, we were not, it was larger than those initial ARB trials, which is only 16 to 19%. And certainly we had all those null trials, so we were becoming quite nihilistic. Here was the canvas, all these endpoints. Again, you can see everything to the left favoring canagliflozin. And I just want to show you this GFR plot because it's going to be relevant for the future things. You initially get a reduction in GFR, and then it flattens out. Now, why do you get the reduction in GFR? Partially, but even before you change volume status, the mechanism I showed you initially. The what? Yeah, you're reducing interglomerular pressure by constricting the afferent arteriole. Thus, your GFR is going to go down. It's the same curve you would see with ACE-ARB, but so I've heard people say, oh, the creatinine's going to go up initially, and then I got to explain it to the patient. Well, you're going to have to, because if it has such beneficial effects, you can't just, you've got to explain this. I call it permissive hypercreatinemia, if you want to give it a term. I use the same term for heart failure, but let the GFR go down. Now, this was a post-hoc analysis from EMPA-REG showing that depending on stratified by their baseline albuminuria status, you have even greater magnitude of effect if they had more severe kidney disease. So if they had macroalbuminuria, UACR greater than 300, that's these two curves. And look, you're getting almost flattening with EMPA, and the placebo group is marching down. Okay? But let me just stress these three trials which show the cardiovascular benefits, which I think is number one. You can't tell patients, we're going to reduce your risk of dialysis, but you're going to die from something else. No, you want everything going in the same direction.
David, quick question.
Yeah.
If you go back one,
Yeah.
at what point did the curves cross, and at what point did you stop seeing the elevated, the worsening kidney function and you get to
Right.
neutral?
Great question. At about 12 to 24 months, if you look at the trials, 12 to 18 months probably. But the thing is, that's for an overall population. You're going to have to explain to the patient, there's no crossing for them other than you have to look for stabilization of the slope, I guess, when you have one patient in front of you. So it may take even longer because you don't have a control group for your patient in front of you. So it just takes your knowledge and finesse and nuance in explaining that to the patient. Yes, it will initially get worse, but long term, it's the turtle versus the hare, right? You're not running a sprint, you're running a marathon here. You're looking at 4, 5, 6 year trajectories, not 1 year. And not to get into nuance, bardoxolone, which was one of the drugs that failed, it increased GFR within the first 4 weeks of therapy, and people were excited at the phase 2. And I remember saying, oh my God, but this is opposite the hyperfiltration story. You're worsening hyperfiltration. How is it going to work for long-term outcomes? And when they did the phase 3, it was completely null, if not, well, no harm. It was just null for any dialysis event. So showing that it's short-term gain, short-term pain, long-term gain, I guess, right? Now, they started with normal kidney function, even though it's thousands of patients with diabetes for years, on average like 8 years of diabetes. They're starting here in the KD-GO heat map of CKD with normal GFR and little albuminuria. So they were low risk, and those analyses I showed you were based on, if you looked at the y-axis, there was 3, 4, 5% event rates for the kidney outcomes because they were starting in this normal range. So there were only 29 dialysis events in these 3 first trials. But then CREDENCE 14, they put out a press release in July of last year, stopped early, and amazingly not stopped early for futility, but stopped early for efficacy. And then it was published this past April after it was presented at the World Congress of Nephrology. And these are not marketing slides. The investigators from the George Institute who ran the trial in Australia put all their slides online. So I took them just because they were pretty and whatever. So don't think this is marketing, okay? Now here we're enrolling chunky DKD, and it's chunky because they all have albuminuria, 30 to 5 grams, 300 to 5 grams. They had GFR between 30 and 90. randomized to canagliflozin versus placebo. And this is an important point. People say, oh, you know, if you see the creatinine rise on the age, when do you stop it? 25% rise, oh, stop it. The protocol said do not stop, even if they doubled their creatinine, even if the GFR went less than 30, even if they were headed toward dialysis, they continued their treatment. Unless they had an adverse event that necessitated, but not for the kidney function itself. I think that's amazing, and amazing perseverance by the investigators. And when you look at a heat map, these now you're getting at least some, their mean was below 60, and they had about a gram of albuminuria. And they got a lot more dialysis events compared to the previous trials. Multinational, almost every continent. Really cool. You know, almost everybody completed the study. I mean, you know, half had cardiovascular disease here. What's important here? A mix of races, although still predominantly white. You can see the geographic distribution. Here's an important slide. 2/3 were on insulin, more than half on metformin, few on GLP-1. This talk is not going to be about GLP-1, but there's also good data on GLP-1 agonists now. And here's the key. 99.9%, 99.9, were on ACE-ARB. Tremendous. Making sure they're on the stupid standard of care that I said wasn't doing that much. But make sure that's happening. And they're about half are on a diuretic. And so people are only like, oh, they're going to get volume depleted. A1C, blood pressure is fine, whatever. Here's the breakdown. Some people fell above 90 or less than 30. Was that whole screening run-in phase? You know, people's GFR moving around. So they weren't going to drop them out if they went to 29 or if they went to 91. Same curves as before. A1C initially comes down. By the end, it's barely different. Blood pressure, 3 millimeters of mercury. But they lost weight, so this is great. Patients are going to lose weight. Albuminuria came down modestly, but the endpoints, now we have primary kidney endpoints, so end-stage kidney disease, doubling creatinine. Renal death is kind of dumb, but maybe some resource-poor countries didn't have time to start dialysis. This was the key slide, the primary outcome. A 30% reduction is primary composite outcome of the kidney endpoints plus CV death. I just can't tell you how robust this is in patients with overt kidney disease. Again, 19 years of graveyard null trials since the landmark IDNT and renal. Just the renal endpoint alone, 34% reduction. End-stage kidney disease, 32% reduction. Another composite here of the hard endpoint, 28% reduction. Everything going in the right direction. Again, you guys haven't suffered through my pain, so this isn't hitting you. The audience literally got up and gave a standing ovation when it was presented at the conference, which I've never seen before at a national conference. Let me teach you guys a statistical thing for a second. When people see this, they say, oh, it didn't work. It worked better in those with lower GFR, but it didn't work 60 to 90. Is that true? Why?
It's not powered specifically for 60.
That's right. It's not powered for the subgroup analyses. And the way you decide whether you can report effect modification or interaction here is this interaction p-value, which was 0.11, which is not statistically significant. Thus, conclude all of these are similar, the confidence intervals are overlapping, and there is no heterogeneity of treatment effect. And another thing is 2/3, now this was underpowered in this stratum, 2/3 had lower GFR, and people complained in nephrology, oh, I'm not going to start SGLT2 inhibitors before CREDENCE, because the EMPA-REG and CANVAS data, they mostly have preserved GFR, and yeah, it worked for those kidney endpoints, but they didn't have overt DKD. You can't have it the other way now. This trial was to enroll people with true DKD, and now you can't say it didn't work in those with preserved GFR. So there's a Bayesian principle, and we already showed it worked here, and B, there's a pure frequentist principle that it was not powered for this specific subgroup, so there's no interaction. Worked for by sex, age, BMI, A1C, blood pressure, similar effects. race, region, same thing. People were emailing me after it only worked in South America. Bull. It worked everywhere. It's p-value is 0.18. Again, all these things didn't matter. And here's the GFR curves. Again, I like taking it from their website because it gave you this thing. Andy, you can see a clear crossover here at 12 months, right? But again, you're not going to have a control group for your patient in front of you. But reduction into glomerular pressure, and then stabilization. This is beautiful. And here I superimposed EMPA-REG, Canvas, and CREDENCE. I mean, it's like, anybody remember 1983, Washington Redskins, John Riggins, they ran the counter tray, Joe Theismann. He would take a step to the left, right, hand off. It's the whole defense. When Riggins would be here, number 44, the Diesel. Anyone remember? Warm up the Diesel. Step, height, step to the left. Whole defense shifts to the left. No, reverse right. You got him going the wrong way. And Riggins ran for 1,384 yards that year and 24 touchdowns, which was later broken by Daniel Tomlinson and Emmitt Smith. But anyway, the touchdown record, single season. They got crushed by the Raiders that year in the Super Bowl. They won the year before. Anyway, beautiful. Reducing every endpoint. Cardiovascular events are now secondary events in CREDENCE. And it's all the same story. I'm not going to read all this out, but just reduction, heart failure, reduction, CV death. Beautiful, beautiful. Oh, makes me cry. There's some hierarchy of testing of p-values here. Just it's all in the same direction. So, statistically significant reduction in kidney failure and cardiovascular outcomes. Safety. Everybody wants to know safety, and I think this is a major issue because I don't have a slide on this, but market uptake of these drugs are still less than 10% in eligible patients. I think one of the reasons are the concerns for side effects. Granted, new drug always takes a little while. But I will tell you this. When that stupid initial Mucomys trial came out in 2001 by Teppel in New England Journal in 92 patients, like the next week we had an order set to order Mucomys pre-CAF. Because there's no side effects and it's dirt cheap. So everyone was doing it. And now, you guys know the story, 20 years later, Mucomys does nothing. Don't be ordering this pre-CAF. So it's not just newness, because we can adopt things and put it in, but there's concern, cost, side effects, etc. So these are I'll show you these outcomes of interest. So overall, if you just pull them all without subtyping, there's actually less, it's kind of amazing. Versus placebo, there's less adverse effect. How is that even possible? It is. Okay, people say, oh, acute kidney injury because they're on diuretics, they're on an ACE, you've got efferent dilation, afferent constriction, you're going to cause AKI. No. This has been shown now in every trial, whether it was EMPA-REG, Canvas program, declared TIMI 18, or CREDENCE, there was not more AKI.
Doesn't that depend on when you look? If you look early, you would see.
Oh, but they don't. These were what they use are the MEDRA codes, where they're hospitalized with AKI, or they have like a doubling in creatinine, or various things. So that early reduction in GFR wouldn't be captured as and called AKI. Now, it's not all bubblegum and apple pie. I don't want to say anything. They do, it's not UTIs. They do not increase the risk of UTIs. This is consistent, and there's even been a meta-analysis now that was published even a few months ago in JAMA Internal Medicine. It's not UTIs. There is an increased risk with all these drugs of genital mycotic infection. And in men, the hazard ratio is 9, and in women, it's twofold higher. Now, absolute numbers, we're dealing with very small numbers here. I mean, 1%, right? So 1% have this. You know, it theoretically is a concern, especially if there's some incontinence there and they're dribbling. You got sweet urine there, and then against the wet, against the skin. So what I heard from George Bacchus, who's a world expert and was on the steering committee of a lot of these trials, including CREDENCE, he's been telling women, I don't know how feasible this is, but he said this just in Philly at a conference I was at 2 weeks ago. Women, he says, he tells his patients to put a little cornstarch in their panties. I don't know if anyone can do that, but that's what he said on stage. For men, I don't know if where they analyzed it, but he seemed to know that this was largely an uncircumcised man. So he advises them vigilant hygiene. He said you can shower twice a day, and I guess it's not much of a concern in circumcised men. Don't shoot the messenger. I'm just telling you. I didn't know this, so I learned. So I'm trying to pass it on to you. Everything else is fine. Oh, and DKA, there's a 0.5% chance of DKA. Hazard ratio is 11. What's happening is they're dumping glucose, so they don't get that. People are checking their finger sticks at home. They're not necessarily dipping their urine for ketones. So you can go into what's called euglycemic DKA. And I'm not sure enough on this, and anybody can correct me. I'm not, maybe. Is always a type 2 a pure type 2? Could they have a mix of autoantibodies and some insulin failure at some point? I don't know, although 2/3 were on insulin. Is it unmasking some of this either underlying type 1 or 2? It just may be that if someone was not on this drug, their sugars would go 300, 400, 500. They'd be like, Doc, my sugars are out of control. They'd say, come in. Oh my God, your bicarb's 12. You got a gap. You got ketones in your urine. You got DKA. Come in for the insulin drip. Now you're at home, you're like, I don't feel well, I'm checking my sugars, they're 180, 200. Everything above 200 keeps getting blocked by SGLT2, dumped into the urine, but they've got smoldering DKA in there. Maybe that's it. I don't know how to pick out these people, it's only 0.5%. I don't think you can create a prediction model. And being hospitalized for a few days, how long do DKA patients stay in the hospital? 2 days, 3 days? Okay, versus a lifetime of dialysis in 176 patients where I call it partial imprisonment. You're going to be hooked up with a fistula, with a catheter, stuck 3 days a week, hooked up to a machine for hours. No brainer, right?
Do you think the DKA finding was similar in other large studies?
Yes. Yes, there is this slight increased risk of DKA. Fracture, there was some noise of fracture in one of the trials. Not happening. Now, amputations. You guys heard this. What happened in the Canvas trial, I'm going to show you on a slide or two. There was a 2 times the risk of amputation in the Canvas program. Not seen with EMPA, not seen with DAPA. It was only that original Canvas trial. And nobody knew the mechanism. So the FDA put out this black box warning. Do I have the date on it? May 18, 2016. I think the black box remains. Jeffrey, do you know? It remains for now? In CREDENCE, there was no increased risk of amputation. And let me show you this. Here was Canvas. 6.3 per 1,000 patient years versus 3.4. Almost threefold increased risk of amputation. That was Canvas. CREDENCE. Now they baseline event rate. The placebo group now has 11%. 11 out of 1,000 of patient years. 11 for 11,000 patient years. So they were higher baseline risk. They were sicker. And now you don't get this increased relative risk. So now we just have one trial out of all these trials that showed the amputation risk. So I don't know if one day they get to drop the black box or not, but maybe that's what some people are worried about. I know midway through this protocol, when the Canvas came out, I guess in 2017 or late 2016, they amended their protocol to tell their doctors to examine the legs. I don't know if that was what changed it or enough to abort it, because they had already been enrolling for 2.5 years at that point. Number needed to treat, again, because you can have a relative risk, like the DKA is a relative risk of 10, but absolute risks are what determine your number needed to treat. The bogey is at less than 100, And look at this, number needed to treat is actually excellent for these major cardiovascular and kidney outcomes. There's a lot more, many more trials going on. There's this other drug, ertigliflozin. There's a DAPA CKD and EMPA kidney trial that, what I wanted to point out here that's really cool, they're rolling diabetic and non-diabetic patients with CKD into these two trials. So we'll see. These will be completed 2020 and 2022. Here's another agent I don't know much about, sotagliflozin. So a lot more data to come. Heart failure, I want to mention this because it just got published recently. John McMurray, who's one of the kings in the field, is talking about how the serendipitous story of this glycemic drug that's now reducing heart failure risk. I showed you early on in one of the few early slides, but EMPA-REG showed these reductions in heart failure. And dapagliflozin, I didn't show you much data on the declared TIMI 1858 trial, but also same thing, reducing in those who had a history of heart failure, showing these impressive reductions. Again, they weren't set up, these are secondary endpoints. And this is the only slide I have about GLP-1. Compared to GLP-1s, which don't reduce heart failure, if you do a meta-analysis of these, you see a 31% risk reduction in heart failure. So, has anyone seen the New England Journal paper 2 weeks ago on DAPA heart failure? I was actually going to replace, I gave this talk 2-3 weeks ago, like the Monday after the weekend of the European Society of Cardiology. And all I got were shots from Twitter from McMurray presenting it. And I was going to replace it for this talk with the New England Journal slides. They suck, actually. There's no good figure. These figures are so much better. So I'm sticking with these somewhat blurry but well-described slides that McMurray had. So DAPA heart failure, guys, these were all patients with heart failure, and they had 45% had diabetes, and 55% did not. They just had half breath. Okay? You can see the New York Association classes, mean EF 31%. They're on diuretics, ACE inhibitors, beta blockers, and 71% on eplerenone and aldactone. Holy crap, this is amazing. They're getting state-of-the-art standard of care for heart failure, and you're going to add on this drug that was initially marketed for diabetes. And wowzers, 26% reduction in the primary composite endpoint. There's McMurray. The beauty of Twitter, by the way, I was watching this almost in real time. Working for every endpoint. You can see his passion. and look at this. Exactly the same whether or not you had diabetes. How cool is that? So, reduce the risk of all the endpoints with or without diabetes, well tolerated, new approach for treatment for HFrEF. So guys, now you got another drug to start.
No hypoglycemia.
No. Now, Emperor is going on. This is empagliflozin in heart failure. I'm not sure when this can come out. Jeffrey, you know when?
Possibly we'll get a readout at the end of the year.
Okay. So here's my summary about SGLT2 inhibitors. We're actually going through this much quicker than I expected.
Is it formulary, doctor?
It is. Oh yeah. I apparently it's still in discussions. There was one of these is going to be on formulary, if not multiple. We'll see, but look out for it and start prescribing. So side effects. Amputation was going on, but not seen in CREDENCE. Dehydration, I'm going to show you some sick day rules. Oh, I got to mention Fournier's gangrene in a second, because I didn't mention that. DKA, absolute risk very low. And then you've got all these benefits. Now, did I stick it in here? I did. Okay. So, guys, who's seen the stuff about the Fournier? Do you guys know what Fournier's gangrene is?
You know what? Yours.
Okay, everyone's done eating, right?
You got pictures?
Yeah, just quickly. But this is the problem that they put out this warning of, initially it was 12 cases reported to this FARS website, the adverse events reporting system that the FDA has. 12. Give me a break, right? But then, I found this funny. Even New York Post caught on to it. The worry is, and then this came out in May in Annals, showing 55 cases from the, I don't know how to say this, FAERS, whatever, FDA Adverse Events Reporting System. 55 cases. What's the problem here from an epidemiologic point of view? What the hell's the denominator? There's no control group. So, of course you're going to report at 4 years on a new drug. Are you going to report it if they were on insulin or metformin to the FDA? No. But now it's a new drug. So there's reporting bias here, potentially. And they even said inability to establish causality, incidence, underreporting, confounding. But now, all you need is a patient to Google this, and you could tell them it's going to reduce heart failure, cardiovascular, dialysis, and they'll be like, got to peel them off the ceiling. No way, because you don't want that happening! That was like 30 milliseconds. Now, this just came out a few weeks ago in JAMA Internal Medicine. It was a letter. They took some online databases and they looked at SGLT2 versus DPP4 and SGLT2 versus GLP-1. Now, here's where you lead to a problem. Like, adjusted hazard ratio was 1.73, 2.52. Confidence intervals crossed 1. So they're saying not significant, but maybe, this is like gray zone. It's like almost worth not publishing it. So let's just assume it's the truth. It's 6.7 cases out of 100,000 person years. Again, super low risk. But, I do mostly, I'm mostly research, and then the time I do is inpatient, and I don't really have an outpatient clinic. But I can't imagine, I'm telling a patient, we're going to reduce all those things, but then it's just, this is emotion. It's not stats anymore, right? I mean, nobody wants to lose their stuff. So I still have the scale tipped towards the benefits, even if you try to put this anvil of Fournier's gangrene on it. I still think, people say, well, what do I do with the diuretics and everything? Use common sense. If they're volume contracted, you're obviously not going to do it. If they're hypovolemic, you're probably fine. If they're euvolemic, what's their blood pressure? If they're hypertensive, great. You're going to get some additional blood pressure reduction. Normotensive, thiazide should be fine. Loops, this is from, I should have put the record. David Cherney, who's another expert from Toronto. So reduce the loop dose by 50% and then start this. Again, no edema, euvolemic, and normal blood pressure. And hypotensive, don't do it. You're going to force more sodium. If you don't want to start a diuretic, then. This is already in the guidelines, guys, ADA guidelines, especially heart failure, CKD, start SGLT2. AHA guidelines, consider SGLT2, GLP-1, talk about it. And then, more guidelines just came out like yesterday or 2 days ago after the European stuff. I mean, it's all over the place. It keeps coming out there. So this is the new standard of care. That's why I said, Teddy, I want to talk about this. Because you guys are going to see it. You're going to see people coming, even if you're not starting it because you're in the hospital, they're going to come in with it. And I think as the heart failure data come out, you're going to see maybe initiation in the hospital. And I know there's even trials ongoing with AMPA to look at diuretic resistance in patients with acutely compensated heart failure, adding it to a loop and metolazone for adjunctive diuretics. Hey, where's my, did I not? Sorry, don't go back there. Maybe, Andy, I tried. I don't know anything about pathways, so I try to make this pathway. Like if we're ever going to start in the hospital, is this too complicated? Yeah. Okay. I want you.
These guys lose tension after one arrow.
Well, good feedback. Yeah, the problem is you got to find the indicated population, exclude the ones that have contraindications, and then.
We can distribute this. I mean, I think people need to know when they should be thinking about it, what contraindications to look at, or so we can get this information out.
And maybe we'll try doing this as a trial, but I mean, again, I think I've told my colleagues, if you're not at least in the outpatient setting, if you're not at least talking about the risks and benefits with your patient with diabetes and kidney disease or heart failure now or high-risk cardiovascular, 5 years from now, it's going to be looked at as malpractice. At least talk about it and say you discussed it. We had one of our chief fellow now, she looked back at our clinic, at the kidney clinic on 102nd Street, and most patients had GFR that was below the criteria. They've actually switched the label now from 45 to 30 with the CREDENCE. But yes, a lot of the people at the clinic already stage 4, but there were, she found over X number of months, the 150 or whatever that were potentially eligible diabetes with GFR above 45 with albuminuria or whatever, and only like two notes out of 152 mentioned that they discussed SGLT2 inhibitors. Maybe the conversation went undocumented. I would think they'd at least put a line, but you got to know about it. And these are the state-of-the-art data, and a lot more are coming. So that's it.
I think one of the things that makes people may worry about starting medication infusion is sort of like time to onset of like decreasing glucose or decreasing blood pressure, because we're often adjusting medications to want to make sure the person's not going to be going out.
That's true.
Of, like, how quickly someone's, because in theory that we would also have to test some other insulin.
That is the other concern about what to do about the insulin that's already on it. I don't know, anyone have any insight? I actually don't have.
I mean, that's my other question, like how much monitoring if we decide to switch these medications on any patients. I mean, I don't think we'll be switching a lot of these medications, but.
No, it'd be more like an add-on. The thing is, do you reduce the insulin dose? Anyone have a good answer? In the trials, they just added it on. Did they change the insulin, Jeff? Do you know?
No, they added it on. Added it.
They have to have an A1C greater than 7, generally.
Hypoglycemia was
Not an issue. Because if your sugar starts going low, you're actually SGLT2 was never at play anyway. It's only the part that you were dumping.
But in theory, you're giving the same amount of insulin.
But physiologically, you can't really get it.
Alone, but like let's say you're giving someone like 30 or 40 units of insulin a day to control their blood sugar and so they're dumping. I don't know, I was just curious about it.
I know,
Thinking about it.
This is my problem. I haven't started it myself either because I do inpatient medicine, so I need to like cuddle with the diabetologist. But the outpatient trials just said continue.
The good news is there's some patients with poorly controlled
Oh,
diabetes.
very point. Right? If you're only right. You,
We have a lot of patients who come in on orals, sometimes more than one oral, and we'll put them on insulin while they're acutely ill and change them back to their orals maybe at the constant charge, and you're saying we should be considering
maybe.
shifting their regimen.
Well, maybe no. We need to consider. I don't know. We need more discussions on when to start. Is there an opportunity to start at least a discharge to get people hooked on it and have them follow up with diabetology and nephrology afterwards? I don't know. It's open for discussion. Again, this is such a moving target. I mean, these things are coming up.
So two questions. So one, do you know what the cost of these things are and the insurance? And then two, as far as like the dynamic with zone in heart failure, I mean, do you think this could be more of a class effect if they were actually studying it further?
I'll answer your second question first because I think it is a class effect largely. We're seeing consistent relative risk or hazard ratios are equivalent essentially, but on all the endpoints, the cardiovascular, the kidney endpoints, it's all been consistent. Maybe I didn't show you much on the Declare-TIMI team. They didn't have as much reduction in cardiovascular, but they were also lower risk to start. Otherwise, it's been completely consistent. For the first question, I'm going to pass that to Jeffrey. Jeffrey's from Boehringer, for full disclosure. He's speaking to him.
You're
Can you introduce yourself a little more?
I'm just assigned to Sinai for medical research, resources, education, clinical data, and as Dr. Coca has mentioned, Emperor is our large-scale heart failure trial, which Sinai is a site of Sinai here, and it's includes. As far as outside coverage, we're in a very advantageous position with empagliflozin, which is Jardiance, was a branded name. The largest payers within the Mount Sinai health system are Health First Medicare, Health First Medicaid, United Healthcare, Oxford Commercial, and AARP, Medicare Part D. Empagliflozin, Jardiance is preferred as the lowest branded copay on the four largest payers within the Sinai system. I can't say the same about the other SGLT2s in the class. I'll leave it at that. There's much less coverage. For one of the SGLT2 members, which is really a free field, has very poor outside coverage. So if a patient were to be started at inpatient or at the clinic, the finding is they end up getting switched to empagliflozin because there's not the coverage. Sure, on a look for a Medicare, let's say AARP, the largest Medicare payer for Sinai and in Metro New York. In a preferred state, you're looking at anywhere between 25 and 45, depending on the plan and the level of coverage that person has within the plan. In a non-preferred but still covered, you're about 80 to 100, and in a no coverage at all, you're in the 300s. Yes, that is a month.
I did have an Uber driver like 2 months ago who told me, he was asking me about his diabetes medicine. He was on one of them, the Imicon or Jardiance, and he said he was on United Healthcare, and I said, what's your copay? He said, $0.
It is possible. Younger gentlemen, older?
40s.
Okay, then yes. In many cases too, we have patient support programs, even for patients that really don't utilize them, but in the copay world, they could have a commercial copay of $0, even though they're already at an advantageous preferred, tier.
Do you know how many people are using this on outpatient side or were these classes?
Well, we've looked at the Sinai numbers. I mean, there were 9,000 in the whole healthcare system in the data warehouse that had been on SGLT2 at some point in time in the last few years. Denominator, the denominator of diabetics here, I don't know, 20,000. But published studies have shown, I mean, it's probably going to be updated. The last published study that looked at EMPA use in using the big databases showed only about 6%, 5.9%.
Very
eligible. Yeah.
Very underutilized for what the data has been. And again, these drugs have been out now for 4 to 6 years, so they're not so novel per se.
Yeah. All right, guys.